Our next presentation is titled A Minimally Interventional Approach Reduces Resource Use and Facilitates Rapid Recovery Following Esophageal Atresia Repair by Dr. Hall.
Thank you for the opportunity to present this work, and we have no disclosures. So the aims of this presentation are to encourage you to consider how you manage infants with esophageal atresia, and to really ask the question, is what you're currently doing evidence-based? Are there any improvements you could make? And then really ask you to challenge current surgical dogma, this concept that we do what we were taught during training or what's historically been done by tradition at our institution. Can we do better? And I'm going to provide you with a set of data to demonstrate you that when we think about that and we remove some of these interventions that may not be absolutely necessary, we can achieve excellent outcomes. And I apologize that some of you may find this provocative. So the rationale for making this presentation is that I think we recognize that in 2023, mortality has ceased to be a major problem, thankfully, in the developed world for most babies with esophageal atresia in the absence of significant comorbidities. And therefore, our focus has shifted to improving other outcomes, reducing treatment burden, perhaps reducing cost as well. ERAS pathways have taught us that many of the things that we used to think were absolutely essential in patient care may actually not be as necessary as we once thought. And using those concepts, we've moved forwards. But we're struck by the fact that many reports of the management of babies with esophageal atresia continue to use what we view as non-evidence-based interventions, many of which we in our centre have long abandoned, and actually some of which we feel may be actually detrimental to patient care. Here's an example, chest drains. We've known for 15 to 20 years that they provide no added value when used routinely following esophageal atresia repair, but they continue to be used. These are just two illustrative examples of case series from both sides of the North Atlantic. So our minimally interventional approach to esophageal atresia repair routinely uses transanastomotic tubes. We don't routinely use chest drains, nor gastrostomies. Our babies don't routinely get central venous access. They don't routinely get parenteral nutrition. We don't routinely do contrast studies. And we follow a practice of early enteral and oral feeding, including breastfeeding when appropriate. So this is a single center series over 20 years. All cases were reviewed, and we selected out cases with esophageal atresia in a distal fistula having a primary anastomosis at their first operative intervention, in order to get around the difficulties of including a whole lot of babies with different comorbidities and case mix. But we didn't exclude anyone on the basis of comorbidities alone. And we included 155 cases overall, and are going to report the outcomes to neonatal discharge. So there were 155 cases, and as you can see, they were predominantly a series of term babies, although 25% were preterm. There was a splattering of gastrointestinal comorbidities along with that, and some cardiac ones as well. We used a transanastomotic tube in 150 of these 155 cases. A chest drain was ultimately required in 8%, and there were 2 neonatal gastrostomies for preterm babies with early recalcitrant strictures. When we look at our feeding outcomes, we were able to start enteral feeds at a median of day 2. And achieve full enteral feeds by a median of day 4. And this really illustrates what we think is a benefit of the transanastomotic tube. We were able to start oral feeds at median day 5, and we avoided PN in 85% of cases overall. As you will appreciate, there was a difference in these feeding outcomes between preterm and term babies, largely solely due to prematurity. When we looked at our length of stay overall, the cumulative benefit of this approach of minimally interventions, removing what you don't really need and feeding them early when you can, and median length of stay to discharge home was 10 days. So just a little word about contrast studies, because I suspect that our practice is very, very different to what the majority of you in this room practice. As I said, we intended to do none. Overall, 9 out of 155 babies had one for a range of clinical indications, as you can see there. But we avoided them in nearly 95% of cases with their burden of not just cost, but also radiation burden that we know is of a high load in these babies with esophageal atresia, but also the fact that if you don't do a contrast study, you don't delay feeding. So I'm sure you'll want to know whether we think this is safe. We can present some data to show that it might be highly effective, but what about safety? Well, we had 1 neonatal death from cardiac disease. We had just 2 anastomotic leaks. Both of these presented clinically, one on day 4, one on day 8, after oral feeds had been started. And there were a number of additional procedures during the neonatal period. 10 infants had an additional procedure of one sort or another, as shown in that table. I won't go through them in detail, but I don't think you'll be surprised to see that sort of range of additional procedures in a series of 150 babies with esophageal atresia. Interestingly, these are not new ideas. The concepts of not using chest drains, not needing to do contrast studies, and having an early feeding approach have been around for over 20 years. But as I say, we're intrigued as to why these concepts are not widely followed. Here's an example of a recent series where we see exactly how they're not followed. And I bring this paper up not to highlight why I think that practice really should change, but really that I want to acknowledge this Midwest surgery group of challenging surgical dogma already, and I urge us all to continue to try and do the same. So our approach to esophageal atresia that I've outlined to you, with minimal use of interventions that we don't think are necessary and may in fact do harm, we believe is both effective and safe. We urge you to continue to challenge this surgical dogma that we have in our units. Strive to implement quality improvements, improve outcomes, and reduce burden and cost for this group of infants. Thank you.
Peter Ann Arbor. Thank you very much for this interesting presentation. One of the things that I wonder about was your endpoint of discharge, because your stricture rate was exceedingly low, but not all strictures are clinically relevant at day 10. Many of them show up weeks later, and I wonder if you can give us some data on your follow-up after that point, because most series report 20% stricture rate, and the paper you quoted from the Midwest Pediatric Surgical found an associations with transamotic feeding tubes with strictures.
Sure, thanks very much for your question. I think, as I've said, these are just outcomes to neonatal unit discharge. Clearly, this is a condition that has lifelong implications, and we know that strictures and their treatment place a lot of burden on these patients. So we routinely monitor our stricture rate annually, and our rate is between 30 and 50%, and we haven't seen that change over time. I think a lot of your stricture rate depends on exactly what you define as a stricture, what your threshold is for intervention in a stricture, but we are aware of the need to do that, and we routinely keep an eye on it over time. I'm going to anticipate there's going to be another question about transamotic tubes, but if there's not, I'll come back to it.
Yeah, Ben Sendejas from Boston Children's. I agree. I was going to follow up on that same issue. Thanks for presenting this, first of all. I do love the idea of trying to avoid esophagograms for low risk anastomosis and potentially chest tubes. But I find it interesting that your initial argument is that the evidence base behind what we do, and there's a lot of evidence nowadays, not just from one center, multi-institutional studies that talk about the transanastomotic tubes being associated with increased risk for stricture, and you are recognizing that you have a 30-50% stricture rate, so why are we still using transanastomotic tubes? And I'm going to follow up that with, if you're feeding them by mouth that early, why not just feeding them by mouth at day 2, 3? I mean, what purpose does a transanastomotic tube have if you're going to feed them by mouth that early?
Thanks for your question. So let's come to the second one first. So we have moved over time to feeding them earlier and earlier. I think we acknowledge that once these babies are extubated, they're swallowing their own saliva. So they've got an anastomosis. Therefore, we are moving to feed them earlier. And that may in turn mean that we start not using transanastomotic tubes in quite so many. We continue to view the transanastomotic tube at this stage as if you like, a security blanket, so that if it does go wrong, then we can still have access and we don't need to get the central venous access and give these babies PN, because we think there's real benefit in that in particular. Regarding the association between transanastomotic tubes and strictures, I think lots of people are concerned about it. We've reviewed the existing literature about it and find that there's lots of confounding in the existing literature that means that we can't draw anything more than an association between the use of TATs and strictures. And the concept there is, I think, if you're a unit who selectively uses a transanastomotic tube, if If you've got an anastomosis that you're concerned about, that's under tension, or there's some other technical factor you're worried about, you're more likely to use a transanastomotic tube. Equally, those are the very babies that are most likely to have significant strictures. So there's a real paucity of data that really convince us that there's a true causative relationship between transanastomotic tube use and strictures. And I think it's an area that we do need to continue to keep under evaluation. And some good quality prospective clinical research in this field would be really useful.
One quick follow-up question. With this sort of streamlined approach to discharge patients quickly, do you have any data on readmissions?
So we have a very low early readmission rate within the first couple of weeks following discharge, other than, as Peter Ehrlich said earlier, for strictures, which can, as you appreciate, happen at any time.
Hi, Sam Sofer from Cohen Children's in New York. I was struck by your low leak rate with 2 patients. Do you think that by not studying most of the patients, you're missing maybe clinically insignificant leaks?
I don't think we're missing them. I think we're actively not worried about them. I think if you've got a clinically insignificant leak, then why would you want to know about it?
That's exactly my point.
Yeah, so I agree.
Precisely.
Yeah.
I think we sometimes see these tiny little wisps and we call them leaks, and,
Yeah.
and it sets us back. And I think that by doing what you're doing, we may well be not missing might be the wrong word, but we may be improving how we can take care of these kids.
Yeah, I think the best way to reduce your anastomotic leakage rate will be to not do a contrast study. So just for clarity, these 2 leaks that we had were clinically very significant leaks, and they were both after baby that started oral feeds. And I think that to us is more of what a clinically significant leak looks like that we need to intervene about. And if we were doing contrast studies and we saw a sort of whisper of contrast outside the lumen, we wouldn't be worried about it.
I can't resist, but how many posterior tracheopexies did you do in your patients?
So we did none, and all of these cases were also done open as well.
Hélène Flajol from McMaster, Canada. A very interesting study. I'm curious how you manage the respiratory post-op status to get them to feed at day 4. Certainly we find in our units that a lot of these kids tend to stay ventilated for 2, 3, or 4 days, which then, makes it very difficult to go home at day 10. So I'm interested in your comments on that. Thank you.
Thank you, yeah. So we very strongly actively encourage our anaesthetists to extubate them at the end of the procedure. And I personally believe this is really key. I think there's a lot of respiratory morbidity to keeping these babies intubated. I think when they go back from the OR onto our NICUs, they very rarely get actively weaned and woken up fairly quickly. They, as you say, often stay 2 or 3 days ventilated, even in babies who prior to their thoracotomy had pretty much nothing in the way of respiratory morbidity. So we actively try and encourage early extubation.
Do they use a lot of regional anesthesia?
So we have been using just local anesthetic infiltration for that. Yeah.
Okay, thanks.
Okay, we have time for one more question from the virtual audience.
Yeah, so this is virtual, but it comes from our program chair, Dr. Van Leeuwen. She wants to know, when do you decide specifically to pull the tube and start your oral feeds?
So essentially, once they are looking like they're swallowing their own saliva and looking hungry and wanting to suckle, we transition them to oral feeds. That includes breastfeeds. We get them to feed with their transanastomotic tube in place, and once we're happy they're actively doing it, we pull the tube out.
Thank you.